discussion because the next paper is by Dr. KRUEGER about novel emerging technology in scleral-based accommodation restoration. That means exactly the same topic, but with a different device. Thank you.
Okay, thank you, Dr. Alio. Guess we can get my slides up here. Okay, thank you. It's the same title as Dr. Ang, but again, it's a little bit different concept and principle in the same tissue, the sclera. So just disclosure, I am a consultant with Alcon, and I'm currently an unpaid medical advisor for Senogen, which is a company that's working on this with novel energy sources, and there's no commercial product as of yet. So the potential for presbyopia market is huge. This is probably the largest refractive market that's really out there that can be tackled with those who actually have the resources to pay for it. About 26% of the world's population is presbyopic, which is over 2 billion people worldwide. With all that, there's really no great way of restoring accommodation, which I believe is the holy grail for presbyopia correction. I think a very important point is lack of accommodation or presbyopia is not entirely due to a hardening lens, but also due to a stiffening sclera. So as a background, holmium laser LTK was done at the beginning of the millennium for corneal reshaping of hyperopia. And for the most part, it worked, but ultimately failed because there was regression of effect. But from that was some understanding to say, could we target this in other structures? And going back to 2008, this is John Kanellopoulos, who treated using an LTK laser on the sclera to see that a patient could not change their distance vision, but actually get some improved reading. From that, there was an investigational feasibility trial that was done in 2013 in the Netherlands, and 100 patients were enrolled, they were followed, and their intraocular pressure and ability to read up close were tested over the course of about a year, and you can see that there was some pretty good improvement in near vision with no change in distance and some reduction of IOP during that same time. So the concepts of LTK were to shrink and soften tissues, whether cornea or sclera, but not to denature it. And to really achieve the shrinkage and the softening effect or increased compliance, you have to keep the temperature range somewhere between 60 to 70 degrees. Once you go up to about 80 or more, you're going to see more denaturation, which is going to lead to wound healing, regression of effect, and that's a lot of what was seen with LTK in the cornea. And so with that, we've been studying different wavelengths in the infrared range, and the 1.55 micron wavelength is really optimal in terms of safety and absorption, and it helps to keep the temperatures in a more controllable manner because it's a very short pulse where the pressure doesn't build up, or the temperature doesn't build up. It also happens to be the wavelength of LiDAR, which is being used for autonomous vehicles. It's in the communities in a large way, and is otherwise very retina safe. So again, the limitations with holmium is in order to get deep penetration, you're going to have to do excessive raise of temperatures, and you're going to get thermal denaturation. And when we did an actual calculation of penetration depth, looking at scatter efficiency and absorption coefficients with different lasers, we found that the pulse diode at 1.55 was going to give more than twice the depth with less real excessive rise of temperature because of the short pulse width. This is all important because we want to be able to get increased compliance of the sclera or more flexibility of this aging sclera. And the reason for that is the posterior vitreous zonule has been nicely demonstrated by Marion Croft to limit the movement of the ciliary body in an aging rhesus monkey as it does in humans as well. And so if we can increase the scleral compliance, that zonule will move once again like it does in a young individual and give us that flexibility of movement of the ciliary body without kind of holding it back. So the concept of laser scleral therapy or laser scleral ciliary translocation is to try to restore those mechanisms of accommodation by treating a little more energy anteriorly, a little bit less energy posteriorly, which is distributed nicely by a diffraction optical device. And it allows the shrinkage more anteriorly to translocate the ciliary body outward and backward, and yet the posterior sclera can be then softened to allow the compliance and movement of that posterior vitreous zonule. This is how it's done with a diffractive optical element where the light can be split out. There's a precorneal interface which protects the cornea and allows the light to distribute, being a little bit more intense anteriorly than posteriorly. For preclinical testing with this wavelength, we've looked at a number of porcine eyes, looking at OCT, OCE or elastography, and also histology with triangulation to see what kind of relationship of the change of shape inside the eye. So with OCT, we can nicely see that treating a therapeutic range, we can open the actual iris ciliary complex by about 4 degrees on average with a treatment that's just posterior to the limbus. With histology, by looking at triangulation of the limbus to scleral spur before and after, we can increase the overall triangulation, which means that that ciliary body is rotating a little bit outward and backward. And that helps to give a little bit more force of contraction at the ciliary body during accommodation. And then finally, with OCE, looking a little bit more at the posterior sclera, we can see that, that the treatment actually reduces the scleral stiffness up to 3 times in the overall flexibility. And we can nicely see some of that shape change in this OCE where the color representation increases and increased scleral compliance. This is how it's being proposed for clinical delivery. It's a simple handheld device that can be mounted onto any existing slit lamp. It's low cost, battery operated, so it's very efficient and inexpensive, and protects the surface, and you can do quick treatments transconjunctivally. It works right through the normal optics of the slit lamp, so you can see what you're doing while you're operating, and there is even a small camera that's located onto the device that will allow visualization during the surgery for those next to the surgeon. Our next steps in the concept would be to do more human biomechanical studies with cadaver eyes, and also some pilot clinical testing where we can kind of refine those optical parameters to optimize, you know, even with using thermal temperature devices to make sure we're in the right range. And then some clinical trials for both safety and efficacy. In fact, we've actually treated now 11 subjects in Slovakia, and you can see that during this time you really see no change on the surface because it's a very low heating effect, but there's good fixation, negligible visual hyperemia, and minimal discomfort. Sometimes patients feel a little bit of stinging, but it's very tolerable for those patients who were treated. In fact, these 11 patients were volunteers. They were all aged from 44 to 63 years of age, and prior to surgery, they were all 20/20 uncorrected emmetropes ranging from -0.5 to +0.75. And after the surgery, their distance vision was unchanged, but they improved by anywhere from 1 to 5 lines. And this is, again, just an early prototype treatment to see what kind of effects we could get without perfecting all the energy delivery to see that it was safe. And we saw that there were no complications with it. In fact, our best outcome in a 44-year-old who was 20/60 near was that they received 5 lines improvement to 20/20, very happy with the comfort and the visual outcome, and it was a simple treatment that just took 1 minute to apply the laser energy to the sclera. So in conclusion, laser scleral therapy is a promising, minimally invasive, and even repeatable method for restoring accommodation that's still going to need further testing. Using a portable, low-cost laser attachment to a slit lamp would make it easy access to a global population with needs in presbyopia. Our pilot clinical efficacy and safety has demonstrated some positive outcome to pursue further, and so formalized clinical trials are planned within the coming year. and we'll make the sclera great again.